So good evening, everybody. Respected teachers, senior pediatricians, Dr. T.P. Jayaram, State President, my dear friends, Dr. Elizabeth, Dr. Sulfi, Dr. Santhosh, Dr. Abraham Paul, Dr. Balnu, and so many of you, Dr. Lelida. I would like to thank IAP Thiruvananthapuram for giving the privilege to be a part of this fascinating CME program this evening. And I would like to thank Dr. Santhosh and Dr. Elizabeth for the kind words spoken about. Now, when Dr. Prashant called me a few days back to give a talk on World Digestive Day, I was very happy about it. But I was rather taken aback when he said that there's no topic for me. There's no specific topic. Still now, I have given only specific talks, so there is no topic. So I thought I will discuss some of the common problems which we come across in pediatric practice as well as pediatric gastroenterology practice, like diarrhea, constipation, recurrent abdominal pain, jaundice, and antioxidants. I will not be touching upon obesity, which will be discussed by Dr. Priya. I would like to take an anticipatory bail, a mungur jamyam, because I'm afraid there will be nothing new for my esteemed pediatric gastro colleagues like Dr. Prashant and Dr. Banu. But I sincerely hope that this talk will be useful for general pediatricians as well as postgraduates in pediatrics. So diarrhea is actually a Greek word which means to flow through and can be defined as a condition characterized by an increase in the frequency, fluidity, and weight of the stool compared to the age and normal bowel habit of the child. But this definition is very important because, as you know, a normal neonate may pass about 6 to 8 stools, loose stools, or liquid stools, which is not diarrhea for him. So the age of the child, the normal bowel habit child, all these are important. If an infant or a toddler is passing more than 10 grams per kg, or an older child is passing more than 200 grams per day, that constitutes diarrhea. So diarrhea in a malnourished, poor malnourished child in developing countries has a bad prognosis compared to diarrhea in a healthy child, like the one shown below. You know that this is the second most common cause of death in children, the first being ARI. There are actually 5 billion episodes of diarrhea every year in the world because each child could develop multiple episodes of diarrhea, and 5 million children die of diarrhea in the world every year. Which means that every minute about 10 children are dying of diarrhea. This is extremely unfortunate because most of these deaths are quite preventable. And 1 million children die of diarrhea in our country. Well, about 9 liters of fluids reach the gastrointestinal tract of an adult, 7 liters from the various body secretions like this, and 2 liters from the food which we take. When I ask our students, especially postgraduates, how much of this 9 liters will be absorbed, they're usually stuck. Many of them say, sir, about 20%, 30%, they may go up to 50%. Well, if only 50% is absorbed, that means that person is passing about 3 to 4 liters of stools per day. So the correct answer is almost 99% is absorbed. Out of the 9 liters, 99% will be absorbed. The small bowel can absorb 7.5 liters, and the large bowel 1.5 liters. So normal stools contain only about 200 ml of fluid daily. Now, what is the surface area? Why is this so? This is because of the surface area of absorption of the human gut. This is simply amazing and enormous, and it's almost equal to that of a single lawn tennis court. Okay, and that is almost 20 lakh square centimeters. So, what is the importance of knowing this? The importance is that you should never starve a child with acute diarrhea because even if some part of the bowel is damaged, the remaining parts can compensate several thousands of times, so that the absorption of fluids and electrolytes will be essentially normal in child with acute diarrhea. So never starve a child with acute diarrhea. There are different methods of classifying diarrhea, and gastroenterologists usually prefer to classify depending upon the site of pathology. We have small bowel diarrhea when the jejunum or the ileum is affected, and large bowel diarrhea when the colon is affected. Depending upon the nature of stools, we have watery diarrhea, and small bowel diarrhea is a classic example of watery diarrhea, whereas in bloody diarrhea is seen in large bowel diarrhea. Depending upon the duration, we have acute diarrhea, which usually subsides in 1 week, may go up to 2 weeks. If it is persistent for a period of more than 2 weeks, it's called chronic or persistent diarrhea. Now, there are some differences between small bowel diarrhea and large bowel diarrhea. Small bowel diarrhea is usually caused by virus, and large bowel diarrhea is usually caused by bacteria. It's also known as colitis. So, a small bowel diarrhea, typical example is rotavirus diarrhea. That's a large stool diarrhea, whereas large bowel diarrhea is a small stool diarrhea. The typical stools of shigellosis will be odorless. There may be some offensive stool in small bowel diarrhea, especially a malabsorption, which is a type of small diarrhea. You get highly offensive stools. Vomiting is more common in small bowel diarrhea, and hence dehydration is also more common. Tenesmus means the painful urge to defecate because of proctitis. If there is colitis, there will be proctitis also. So the child feels that there is more stool to be evacuated. So what happens? The child will go on sitting in the toilet. He refuses to get up from the toilet. So it's said to prevent others from going to the toilet, especially if there is only one toilet in the house. Perianal excoriation is common in small bowel diarrhea due to lactose intolerance. And remember that colitis is a potentially fatal disease, especially because of HES. This is a pictorial depiction of colitis or large bowel diarrhea. Actually, the slides were drawn for me by one of my old students belonging to the 35th batch of Calicut Medical College, Dr. Anil Salim, who is a brilliant cardiologist now. Okay. So large bowel diarrhea colitis. When I showed this slide to Calicut Medical College students, many of them said, sir, this should be the old third men's block. In the old third men's block, many of the toilets are not functioning properly, and many of them did not have a bolt. So these students, medical students, had probably colitis. They developed colitis by eating outside. There are so many unhygienic hotels in near Chevire. Maybe they developed colitis. You can see that this chap is keeping the door closed with his foot because there's no lock, and his friends are anxiously awaiting the time. So a child, if it develops colitis, he prevents from others from going to the toilet, especially if there is only one toilet in the house. On the other hand, in a child with malabsorption, small bowel diarrhea, he passes such highly offensive stools that he literally drives away the other members of the family, not only from the toilet, but from the house itself because of the severe smell. Well, eat cricket, sleep cricket, drink only Coca-Cola. There's nothing official about it. I'm sure you will recall this popular advertisement during the Prudential Cup tournament some time back. Of course, there's nothing official about it. It's a war between Pepsi-Cola and Coca-Cola. The problem was that many of the youngsters had taken this to heart. Once I had to look after one of my cousin's son, who was studying, who was an engineering student. He was having dyspepsia. The parents were very much upset about it. So when I took a history, I found out that he was never drinking water. He was an engineering student, and daily he was buying 2 big bottles of Coca-Cola, and he was literally drinking only Coca-Cola. That was responsible for his dyspepsia and abdominal pain. And he became all right after stopping Coca-Cola. And we know that a lot of our cricket heroes were forced to take leave, and many of them cite injuries. But what I believe is that some of them at least have got a chronic diarrhea because of the constant thunder that they are so regularly tasting. These are some of the signs of severe dehydration which we do not see now across. Presently, we do not come across such patients thanks to the ORS, which has been hailed by the WHO as one of the fantastic discoveries of the 20th century, which has literally saved the lives of millions of children with diarrheal disorders. Now, what is the role of stool culture in acute diarrhea? Now, when talking about the culture, I am always reminded of my best teacher, Rajavan sir. Rajavan sir used to say that Keralites are culturally backward. He was actually scored in PGs for not doing a blood culture in a patient with suspected septicemia. But acute diarrhea is one condition wherein stool culture is not required, because if you do a stool culture, what will happen for a 6-month-old baby with watery diarrhea, you will get a stool culture report as E. coli sensitive to netilmicin or meropenem. Doesn't make any sense because E. coli is a common cell. Should never change antibiotic or start a new antibiotic just based on E. coli, unless the E. coli can be tired, and it's very difficult to type E. coli. And for watery diarrhea, stool culture is not at all required. It may be required only if you are suspecting shigellosis or there's an epidemic of shigellosis or cholera. What is the role of stool routine examination in ADD? Well, I think there is no role. I'm sure that there is no role for stool routine examination also in a child, say a 6-month-old baby with acute watery diarrhea. If you do a stool routine examination, you get the result as 0.5% stool percent. And the mother promptly mistakes this for diabetes. The stool. Pansara no ornal, that is diabetes. So once I got a call from a very close friend of mine at 12 12 o'clock in the midnight. He wanted an immediate appointment with me because his wife, he came just after 2, and the wife told him that their only child after 10 years of marriage has got diabetes. So it's better not to do stool sugar. We'll try to explain that investigations are usually not called acute diarrhea disorder. Another of my friend's patient, it's a child, he had acute diarrhea disorder. He was shown to me on the day 7. He was a very anxious person. He had already seen 2 or 3 pediatricians. He wanted an immediate cure. And he was literally pleading with the doctor, please do some investigation, at least a stool examination. So I had to give a prescription for a stool routine examination. Okay. Then he did not come the next day. In fact, he came only after 2 days, and he had an apologetic look on his face. He said, "Doctor, I'm very sorry, I could not do stool examination as my son has not passed through for more than 2 days." Okay. And in spite of that, he was asking me, shall I do it tomorrow? The child is actually constipated and still wants a stool examination to be done. This is the level of some of our patients. Now, some prescriptions for acute diarrhea disorders are literally shocking and actually unbearable. I will give an example of such a prescription. Well, I joined Calcutta Medical College in 1993 after passing DM from Trivandrum Medical College, and I was in charge of the DTU. Okay, and then we got this prescription. One of the patient, a 5-month-old baby with acute diarrhea, was referred to our DTU, and we were all shocked to see this particular prescription. This happened almost maybe 30 years back, and I have removed the name of the pediatrician. Everything about the pediatrician is not removed. But let's see this prescription. You can see that this is Priya, a 5-month-old baby with acute watery diarrhea. Number 1 is injection Kemzole. Any idea what is injection Kemzole? Prashad, chat box. Injection Kemzole. Yeah, the chat box will some questions.
Sir, your audio is not audible. Audio is not clear. Audio.
No.
Audio is not clear, as well as you are out of focus. You are out of focus also.
Audio is not clear.
Audio is not clear. In between there is some blurring.
Okay. Wait a minute.
I think it is clear, sir. I think the problem is with you, I think.
Prashant, clear ആയിട്ട് കേൾക്കുന്നുണ്ട്.
Clear ആണല്ലോ, problem ഒന്നുമില്ലല്ലോ. Voice is also clear.
It's very clear. It's very clear, sir. You go on. Go ahead, sir.
Carry on, sir.
Sir, it's very clear. Your audio is very clear. You go ahead, sir. It's clear.
So there is no problem actually.
Okay. Please unmute, sir. Sir.
Hello.
Now audible, sir. Audible.
Nina, mic talk directly to the.
Yes, sir. It's very clear.
Okay. So after joining Calcutta Medical College, I worked in the DTU, and I had a prescription. A 5-month-old baby with acute watery diarrhea was referred to DTU. Was seen by a pediatrician. So let's see this prescription. Priya, 5 months. Okay. The first drug is injection Kemzole. You know what is injection Kemzole? Kemzole is cefazole, injection cefazole. The second drug is injection garamycin. What is garamycin? Garamycin is gentamicin. Okay. Then he has drawn a line here. Can you see that? The third drug is tap norfloxacin, 200 milligram, 1/3 BD. The fourth drug is Nalp suspension. Remember that norfloxacin and nalgesic acid belong to the same group, quinolones. The next drug is metrogyl F. Actually, there are two drugs, metronidazole and furosemide. Okay, and the next drug is Vitalact, which is a lactobacillus preparation. So you can see that, this doctor had, in the reference letter he had written, in spite of all these drugs, diarrhea is persisting on the second day. So we are literally shocked to see this prescription. We stopped all drugs, just gave ORS. Remember that zinc was not available then, and the child became all right within 48 hours. Prashant, കേൾക്കുന്നുണ്ടല്ലോ?
What is that? What is that?
Yes, sir. Yes, you are audible.
Okay, right.
Okay, sir.
So here you see two illogical or irrational combinations. You can never see a penguin in the desert, nor can you ever see camel in the cold Arctic or Antarctic region. Just as illogical as this combination are, some of the drug combinations in infantile diarrhea. For example, you can see that this baby is vomiting and is given drugs like Gramogil, non-metrogyl or estrogel F. Gramogil actually contains nalgesic acid and metronidazole. Nalgesic acid is notorious to cause nausea and vomiting. And have you ever taken metronidazole yourself? It causes severe nausea, vomiting, and you have got a metallic taste. You lose your appetite for several days. So if a child is already vomiting, if such a drug is given, what will happen? He will refuse to eat. If it doesn't eat, what will happen? He's already having mild PM, and his mild PM may become severe PM, and the acute diarrhea may become persistent diarrhea. So as far as possible, you should not use combination of drugs. Now, if you want to use a combination, what should you do? You should use a typical example of an ideal combination is this. Okay? This is a very good combination, which we are all very fond of. Or something like this. This is masala dosa and sambar. Very good combination. This is actually from Tamil Nadu, not from Kerala. And this is the North Indian combination, chapati and aloo. Again, very good. This is the idli, sambar and chutney. Again from Tamil Nadu, but we are also very fond of it. What is the Kerala delicacy? That is puttu and kadla. Now, I remember that Professor Lulu Matthew, she's always very fond of mammootty. So if you don't show mammootty, she'll be very upset about it. So these are some of the ideal combinations. Okay. Now, what is the ideal combination in acute diarrhea? That's always zinc and ORS. The ideal combination in acute diarrhea is only zinc and ORS. So use only zinc and ORS. When that patient was referred to, that happened in 1995, then zinc was not available, only ORS was available. Now, recently when I took a class on nutrition, I asked undergraduate students, which is the only animal that drinks milk after infancy? The only animal that drinks milk after infancy. What we expect is naturally human beings. But a fellow sitting in the back of the class surprised me. He said, "Sir, the cat." I'm sure that I'm very happy to teach undergraduate students. I really learned a lot from a student, especially undergraduate students. I really love teaching not only postgraduate but also undergraduates. It's really rewarding to teach undergraduates. Some of these fellows are very humorous also. Now, unfortunately, many of our mothers, especially young sophisticated mothers of Calcutta area, Malabar area, who just returned from Gulf countries, so many of them are reluctant to breastfeed the baby because they feel that formula feeds are superior. So let's see how these formula feeds are prepared. You can see that this cow has been milked. All the good ingredients of the milk have been removed to make butter, cheese, and to the definitely inferior cow's milk, they're adding some oil, some vitamins, and through a series of processes, it's marketed in a till, which is labeled as the ideal till, ideal milk. But just look at the face of this baby. He looks gloomy or depressed because he is sure that this is not the ideal milk for him or for his friends. Even this cow is shocked. She's exclaiming, "You must be joking to call my milk the ideal milk for your baby." Remember that cow's milk is destined by God for the cow's baby and not for the human baby. Now, in conclusion of diarrhea, is actually a very nice poem by Academy Today, published in 1995. Diarrhea is a nutrition disorder. Improper treatment is hazardous. Always continue breastfeeding. Antimicrobials are usually not required. Reserve IV fluids only for severe dehydration. HAF, that is home available food, should always be given. ORS is the best drug for diarrhea. Always encourage the intake of a normal diet and avoid the use of unethical drugs. Now we'll come to constipation. Another very common problem encountered not only by pediatricians but also by pediatric gastroenterology, because almost 1/4 of all pediatric gastroenterology consultations are for children with constipation. And this is usually a very chronic problem and needs long-term therapy with laxatives. Defined as a difficulty or delay in defecation present for 2 or more weeks, causes significant distress to the patient without any structural or biochemical explanation. It's a multifactorial pathophysiology. The main problem is child has got maybe a small fissure so that there is a dyschezia. If the child tightens the gluteal muscles and the external sphincter, so there is more and more stool accumulates in the rectum, which dilates, accumulates more and more, and that results finally in a megarectum. Rectal sensation to the person of the stool is lost, and finally the desired to pass stool also disappears. If there is a fecal impaction, many children, especially girls, present with recurrent UTI. You know why? Because the impacted rectum will obstruct the small urethra of girls, resulting in retention of urine and also recurrent UTI. So when a child presents with recurrent UTI, always consider the possibility of a hidden chronic constipation also. Encopresis is one of the terrible symptoms experienced by many of these children. It's the involuntary passage of stool into the undergarments. Let's see how this happens. When there is rectal impaction like this, you know that these stools will be very hard, rock hard in consistency. Okay, then you should remember that normal stool, liquid stool, is always coming from above, and this liquid stool will percolate around the hard stool in the rectum and will come out of the anus without the child's knowledge. That is called encopresis. This can be compared to a traffic block like this. When there's a traffic block like this, what will the motorists do? They will take a detour like this and come out. So this is exactly what happens here. The normal stool, the liquid stool, percolates around the impacted stool in the rectum and comes out, causing encopresis. So this is actually a vicious cycle: painful defecation, voluntary withholding, more pain. There's a vicious cycle, and should be the endeavor of the pediatrician to break this vicious cycle. Now, we Indians are ridiculed by Westerners for so many silly reasons. They ridicule our marriage practices. They say that Indians are shameless bargainers. But I've seen many Westerners, especially when they come to India, bargaining shamelessly. They say that we barge into others' houses without any individual. That is true to some extent, because many a time we visit our friends or our relatives without informing them, and that may cause confusion, difficulty for them. That is, of course, correct. And we have very poor concept of zebra. That is also absolutely right. Then they say that we play gully cricket. They ridicule us for playing gully cricket also. But there are two great innovations by Indians which have very much impressed me as a pediatric gastroenterologist. Now, what are these? Now, when the Westerners in the 16th and 17th century, they were fascinated by castor oil. They thought that castor oil is a panacea for all sorts of ailments. So the mothers in the 16th and 17th century were giving castor oil to children even with diarrhea. But the result was that the mortality was very high in children with diarrhea in those days. On the other hand, at that time, our mothers or our grandmothers were giving children rock salt. You know that rock salt with water. Rock salt is full of sodium and potassium. Now, this means that our forefathers were aware of the importance of ORS even 2 or 3 centuries back, even though Westerners were giving castor oil for diarrhea. The other one is the practice of squatting. According to Baucus textbook of gastroenterology, the ideal posture for defecation is the squatting position with the thighs fixed upon the abdomen, which is adopted by Indians for decades. Now, let's see some history of squatting. Ever since Adam and Eve descended on the earth, we have been squatting for defecation. This continued even with the advent of civilization. You can see that even the fetus adopts the squatting position, at least initially. And the infant, if he wants to poo, he instinctively adopts the squatting position. The flush toilet was invented in the 19th century, and this was initially limited to royalty. You know why? Because it resembled sitting on a throne, hence it appeared more dignified. So initially, only the king and the queen were allowed to use the flush toilet. After that, it became very common, and all Westerners started using this type of toilets, whereas Indians continued to squat for defecation. And hence, constipation was very rare in our forefathers compared to the Caucasians. Now, why is it so? See, when you are squatting like this, what happens is that the puborectal muscle is relaxed. So the rectum comes in a straight line with the anal canal. On the other hand, when you are using the European toilet or the flush toilet, the puborectal muscle is contracted. That will produce an acute angulation between the rectum and the anal canal, and it's actually difficult to defeat. Now let's see a clinical puzzle with constipation. Now this child was referred to as for development delay and constipation. What are the findings on his face? You can see that he has got puffy eyelids. Okay, puffy eyelids, delayed development, constipation. He also had radial delay and a grade 2 ejection systolic murmur. So what will be the first diagnosis? The first diagnosis obviously will be hypothyroidism. So the pediatrician was very happy because he thought it is hypothyroidism. He did TFT, but unfortunately, he was very much disappointed because the TFT was normal. So he repeated it twice. Again, that is normal. So this child had to be referred to us. So now can you look at this? Another patient with the same syndrome. Look at the iris. This is called Steary Iris. So this child has got blue or Steary Iris. You can see the periorbital edema, depressed nasal bridge. Look at the philtrum, it's very long. Small, widely spaced teeth, ear to ear smile. What the diagnosis? Prashant, anybody has got the diagnosis here? Prashant? In the chat box, anybody has got the diagnosis?
Yes, they have written Williams.
Yeah, that's absolutely right. Elizabeth?
2, 3.
So many people have written.
So,
Sir.
okay.
Many have written.
The full name is Williams-Buren syndrome. So what is the cause of constipation in this child with Williams syndrome? What could be the cause of constipation? Why was he constipated? Because of hypercalcemia. Hypercalcemia is one of the features of Williams-Buren syndrome. His calcium was more than 13.5. What is the cardiac lesion? It's usually supravalvular aortic stenosis. That was responsible for the mild radial delay.
Even they have answered hypercalcemia.
Hypercalcemia. Okay, right. Very good. Must be your students. A 5-year-old unimmunized boy was treated for pertussis, and he presented to us with the chronic constipation, severe dyschezia. Both the parents as well as the grandparents were very much worried because of the severe dyschezia. He also had hematochezia. Okay, he was extensively evaluated and treated without any relief. So he was really referred to us, and we could make a diagnosis from treatment history alone. Remember, he was treated for pertussis. So in Calicut in those days, രണ്ട് മരുന്നുകളുണ്ടായിരുന്നു. കൊരയ്ക്ക് കോറക്സ്, പനിക്ക് പെരാക്സിൻ. കൊര എന്ന് പറഞ്ഞാൽ ഇവിടെ കൊര എന്ന് പറയാം. You call it as ചുമ. കൊരയ്ക്ക് കോറക്സ്, പനിക്ക് പെരാക്സ്. Paraxin is chloramphenicol. The Corex, what does Corex contain? Corex is one of the sweetest medicines. Okay, it contains codeine. So this child is very fond of Corex.
Dr. Nagalada has written codeine. Dr. Shabla has written codeine.
Okay, very good. So this child was literally drinking half a bottle of Corex daily because it was very sweet. His constipation was only due to Corex, codeine. So he became all right when that was stopped. This was another very interesting patient. You can see there's an old patient of mine. The male child was referred for constipation. Okay, the parents became upset, and he had mild development delays. The parents became upset when the 4-year-old sibling became taller. Just look at the face. He's got a dull look. Look at the eyes of this child, the girl child, and they're very sprightly. He's got a dull look, depressed nasal. This is actually a case of hypothyroidism. We just missed for congenital hypothyroidism. We just missed for a very long time. So we started L-Troxin. Within 1 year, you can see that he has become taller. 10 years, very tall. He's raising his fingers in the victory sun. 16 years, there was no constipation. But unfortunately, he had severe behavioral problems. He was a very aggressive child. Only because maybe, that thyroxine is essential for the normal development of the brain. It really doesn't matter if a pediatrician misses a diagnosis of Williams-Buren syndrome. It really doesn't matter. But as pediatricians, we should never, ever miss a diagnosis of congenital hypothyroidism. Now it's difficult to miss it because we are doing newborn screening. But even then, occasionally we do come across patients with hypothyroidism. So another patient with abdominal pain and constipation. These are the two clues. And I'll give a better clue. A better clue for this child with constipation and abdominal pain was this. Now, who is this? Prashant, adding diagnosis. Who is this lady?
Lead poisoning, plumbism.
This lady.
Lead poisoning, plumbism.
Lady.
Lady, no.
Lady, nobody wrote.
Usually, most of my students diagnosed as Marilyn Monroe. Marilyn Monroe is actually the differential diagnosis. Diagnosis is Elizabeth. Now, what is Elizabeth Taylor got to do with constipation? Now, you know what was the Elizabeth Taylor's favorite hobby? Elizabeth Taylor's favorite hobby was getting married. She was married 7 or 8 times. And who was this? This was her most favorite husband. She married him twice and divorced him twice.
The slide.
Anybody? Who is this? This is Richard Burton. So if you know Richard Burton, you can diagnose this condition. Now let's see this again. You can see that there is a dark line. This is called the lead line or the Burton's line. Okay. Now let's see the peripheral smear. You can see hyperchromic microcytic RBCs, basophilic strip. And as your students have rightly pointed out, this is a case of plumbism or lead poisoning. Is also known as saturism. So his abdominal pain and constipation were actually due to plumbism. His father was actually a painter, and he had severe iron deficiency anemia. Maybe he had pica and he was taking a lot of paint. That was responsible for the plumbism and constipation in this child. Now, what's the cause of constipation in this child? Anybody? Can you spot the diagnosis? What could be the cause of constipation in this child? What are the findings in this child? What could be the cause of constipation? General examination is very important for pediatricians.
Neurofibromatosis, the answer has come.
Yeah, you can see that he's got cephalomicals. He has got multiple cephalomicals and he's got neurofibroma on his upper lip also. This is actually case of type 1 neurofibromatosis. So what could be the cause of constipation in type 1 neurofibromatosis? A spinal cord neurofibroma. It's actually due to spinal cord neurofibroma. So even they can also present with constipation to the pediatrician. What is the role of investigations? This is one condition where a good history and physical examination are confirmatory. Actually, investigations are not required in functional constipation, but I always do a thyroid function test because at least I picked up at least a couple of cases which I thought never the thyroid function is never going to be abnormal, but in these children, thyroid function test was abnormal. He had hypothyroid. They had hypothyroidism. So I always do a TFT, and sometimes I do a calcium and potassium also. Otherwise, usually, if you take a good history and physical examination, you don't require any investigations. The goal of treatment is long-term treatment with PEG polyethylene glycol. And it's very important that all pediatricians have a copy of a Bristol stool chart in your consultation room. And the idea should be to have the child should be passing type 4 or type 4 sugar, and resolution should be of a soiling, return of rectal sensations. Now, unfortunately, almost 50% of patients treated for functional constipation, they will recover they will relapse within 1 year. The total duration of treatment may vary from 6 months to 24 months. I always treat usually up to 12 months. And this is extremely frustrating for parents and the children. So the pediatrician should always take an anticipatory bail. What is the anticipatory? It should be like this. I'm sure you know this famous thing. The film Elizabeth. It's so popular. You know this film? Prashant, film this is a very famous dialogue by Papa. Problem is never going to be all right. Now I'll talk about a few slides on recurrent abdominal pain. Again, one of the most common medical problems in children. Almost 10 to 15% of school-going children have got recurrent abdominal pain. And almost 1/3 of all pediatric gastro consultations are for children with recurrent abdominal pain. So the very important cause of school absenteeism, depression in children. This is due to, there is a gut and brain connection, something known as visceral hyperalgesia. Because of visceral hyperalgesia, what happens is that even normal physiological stimuli, like a normal peristaltic way, will be perceived as painful stimuli. In the evaluation, we should always exclude organic causes. Unfortunately, there may be anxious over investigation, or sometimes there may be complacent under investigation. Both are detrimental. Now, what is Apley's law? John Apley is put forth his law that he said that the further the pain is away from the umbilicus, the more likely it's of organic pathology. So the pediatrician should actually be happy the child is pointing to the area around the umbilicus. That's likely to be a functional pain. History taking again is very important. A detailed history, you may have to spend sometimes 30 to 45 minutes with the history taken physical examination. And these will definitely reassure the parents and child, because the parents now feel that the pediatrician is really worried or concerned about their child. Or ask for a history of celiac disease, inflammatory bowel disease, the family peptic ulcer disease, is there a history of irritable bowel syndrome, is the child taking plenty of fruit juices, chewing gums, candies containing sorbitol, and is there a history of abuse, sexual abuse as well as physical abuse can result in recurrent abdominal pain. There can be sometimes be migraine, which may present as abdominal pain. Now, who are irritated in irritable bowel syndrome? Who are the people who are irritated in irritable bowel syndrome? Naturally, the child, the patient is irritated, the parents are irritated, and also the pediatricians will also be irritated because the child, they keep on bringing back the child to the pediatrician saying that, doctor, there is absolutely no relief, we continue to have pain. The ABC of IBC, abdominal pain, bloating, and change in bowel habits. But what we should remember is that the pain is actually real. The child is not faking pain. This actual child is actually experiencing pain. Suppose there is a very tough teacher like this. Whenever they're about to go to school, and when they think of their teacher's face, they suddenly develop an increased contraction of the gut or bowels, resulting in abdominal pain. So the pain is actually real. The child is not at all faking. So many people call it as, there's even a term called pretendicitis. Okay, they believe that the child is pain. It's not pretend, it's actually true pain. It's not pretendicitis. What is the role of stress? There's a very famous statement by Grossman. The more sophisticated the country is, the more belly aches there will be. And little belly aches like this will develop in an adolescent with belly ache or an adult with belly ache. That's the role of stress. What is umbilical sign? When you ask a child with a functional abdominal pain, where is your pain? He will usually draw a line around the umbilicus. I tend to call it as the umbilical sign. I am very happy this sign because many of my patients they'll draw a circle around the umbilicus, which is reassuring actually. What is closed eye sign? Now a child with functional abdominal pain is sure that the examination is not going to hurt her. So she will keep the eyes closed. This is called the closed eye sign. So again, I'm finding suggestive of functional pain. What is stethoscope sign? All the models are my own students. This is Rajalakshmi, one of the best intensivists. Now she's in Trichy Medical College. What is stethoscope sign? This is Vivek Raj, one of our best neonatologists. You can see that Vivek is a tough-looking PG. Is applying the stethoscope sign. He's actually pressing the painful area. But this child is not at all bothered because he's got a functional pain. He's sure that the doctor is not going to hurt him. He's busy reading his comic. But when he's examined by a lady PG, you can see that he stopped reading, he's smiling at her. That may be adolescence for him. Now, what is the aim of treatment of functional abdominal pain? It's not complete relief of pain, but we have to reassure the parent that their child does not have a serious underlying pathology. We have to coax children to normalize their daily activities, schools, meals, play, etc. Encourage them to focus on studies, sports, extracurricular activities. I know that it's very difficult now because of the COVID. Never accuse a child of malingering. We already told you that the child is actually experiencing pain. She is not at all malingering. The pain is genuine. It is felt by the child. The regular and diligent follow-up are essential. And should avoid, I'm sure you know what is a FODMAP. Antispasmodics may also aggravate pain. Now we come to the next topic, which is antioxidants and free radicals. I'm actually venturing into Elizabeth's zone, Elizabeth's area of interest, with due apologies. You know that antioxidants are the soldiers of the body that protect us from our enemies of the free radicals. So antioxidants can be considered as soldiers and free radicals are our enemies. And what is the free radical? A free radical is a molecule which has lost one of its electrons. When a molecule loses its electron, it becomes highly reactive. So it will try to stabilize itself by grabbing an electron from a normal molecule. And in the bargain, the other molecule will become a free radical. Thus, once a free radical is formed, that will convert millions and millions of nearby molecules also into free radicals, thereby causing extensive tissue destruction. Now, what does an antioxidant do? An antioxidant is a substance which donates one of its electrons so that the unpaired electron is paired. Now that becomes neutralized. So these are highly reactive, and they are often referred to as the rowdy molecules of the body. Okay? Free radicals are often referred to as the rowdy molecules of our body. And they're so reactive. Free radicals are so reactive that they may be compared to a virulent bachelor like him. On someone like him who's not only virulent, sometimes destructive also. So how do you tame such a person, destructive person? He's the free radical. How do you tame him? You get him married or you get him paired. So Katrina Kaif is the antioxidant, and Salman Khan you can remember as the free radical. This is a list of the free radicals, and the most toxic, most potent of all free radicals is the hydroxyl radical. These are some of the internal source of free radicals. Remember that every minute, every second in a body, millions or tons and tons of free radicals are being continuously produced. Even during phagocytosis, free radicals are produced. These are some of the other sources of external sources of free radicals. Alcohol. Now women have taken to alcohol, especially in the Western countries, in a big way that can cause free radicals. Automobile fumes. We're all fond of Kentucky Fried Chicken, but when chicken is fried or fish is fried, what happens? Free radicals are produced. So whenever you take a KFC or a fried fish, always try to quench the free radicals which you have taken by taking plenty of fruits and vegetables. Now, this is a delicacy from Calicut. But you can see that this person never changes the oil. He is the day in and day out using the same oil. When the same oil is used, that will produce free radicals. So these delicious appearing banana chips are actually not good for our health. Now, what are negative thoughts? It has been found that negative thoughts can reduce superoxide. These are the antioxidant levels, can cause what is known as an oxidant stress. So what are negative thoughts? Greed, anger, jealousy, and hatred. So we, especially pediatricians, should never be greedy. We should never be angry with others. We should not be jealous of others. We should not hate others. All these will produce free radicals in the body. So, as I already said, every second, millions of free radicals are produced, are constantly being produced. Fortunately, we have got a very efficient antioxidant system. So, it's a very delicate balance between free radicals and antioxidants. If there are more free radicals than antioxidants, then that would be disastrous for our body. So, this is the list of some of the antioxidants. The biological antioxidants, this is the intracellular enzymes like superoxide dismutase, catalase, provided to us by Mother Nature. Then we have the dietary antioxidants, trace elements, plant antioxidants, etc. Then this is a list of the carotenoids. Remember that there are actually more than 400 different types of carotenoids. Beta carotene, lycopene being the most important ones. So if you try to get antioxidants through pills, what will happen? You get only beta carotene. So you should try to get your antioxidants, especially carotenoids, from your food and not from the pills. This is the beta carotene content of fruits. You can see that one of the richest sources is the watermelon, followed by mango and papaya. Now, papaya is very commonly seen in Calicut, Malabar area, but unfortunately, many people, especially the villages in Calicut, Malabar area, they are not fond of papaya. Instead, they give papaya to the cattle. So the cattle in this area, you can see they are very healthy. They are very fond of papaya. They get a lot of antioxidants. So the old story of the rabbit and the tortoise race, and the tortoise beating the rabbit is the tail. You can see that the rabbit is the comprehensive winner. Why the rabbit is the winner? You know that the greatest carrot eaten in the world is rabbit. So his body is full of beta carotene. So the old story, the other story is actually tail. Now that takes us to the $1 billion. Can carotenes really prevent cancer? A lot of research is going on. Many people believe that the carotene cannot prevent, but there are some schools of thought that they may prevent cancer. One theory is that beta carotene can increase tumor necrosis factor alpha, which can detect and destroy cancer cells. That's the reason why we believe that fruits and vegetables may prevent cancer. Or meditations, including yoga, can increase the production of antioxidants in our body. So the importance of relaxation. When Obama became president in 2008, was looking very active, very healthy. In 1 year, he was looking like this. This was how he looked in 2014. But of course, he's much better now because is able to relax a lot now. So relaxation is very important. And this may not be the ideal method of relaxation for carelites, but the message is very clear. All doctors, all of us, including pediatricians, to take time to relax. Now, these are new concepts. Fruits and vegetables that resemble our body parts. Do they help in the health of these body parts? Fruits and vegetables that resemble our body parts, can they help in their health? For example, what is this? Well, you can see that this is a carrot. Which organ does it resemble? Prashant, which organ does it resemble? Carrots, a cut carrot resembles the eyes. Now we know that carrots are rich in
Iris,
beta-carotene.
the answer has come.
Yeah, that's very
Iris.
useful for the health of the eyes. Now, what is this? Prashant, now what is this fruit? This is the walnut. Which organ does it resemble?
Walnut, the answer has come. Brain.
Yeah, which organ resembles the brain? It is such a striking similarity between walnut and brain. And walnut contains omega-3 fatty acids, which is very important for the healthy brain function, may even reduce the risk of Alzheimer's disease. This is the tomato. What is the antioxidant present in tomato? That is lycopene. And it resembles the chambers of the heart. It may be good for the health of the heart. What is this and what does it resemble?
Lycopene, answer has come.
Okay, thank you. And what is it resemble? This is നമ്മുടെ ഇഞ്ചിയാണ്. Which organ does it inji resemble? Inji resembles the stomach. For decades, for centuries, our grandmothers give us the inji nira. When you got an upset tummy, I still remember my grandmother gave me inji nira when I got a tummy ache. What is this? This is sweet potato, which resembles the pancreas. It may be good for the health of the pancreas, rich in beta-carotene. What is this and what organ does it resemble? What is this fruit and what organ does it resemble? This is the
avocado.
Avocado.
Uterus. The answer
it resembles which organ? Avocado resembles
uterus. The answer.
The gravity is full of folic acid. Now you know that is very important for the fetus. In fact, we start supplementing the mother with folic acid right from the preconceptional period. So avocado butterfruit is very useful for the pregnant woman. Kidney beans, good for the health of the kidney. Bunch of grapes resemble the alveoli, may be good for the health of the lungs. Similarly, what is this? And which organ does it resemble? This is olive. Olive resembles the ovary. It may be good for the health of the ovaries. It can decrease hot flushes of menopause and may even reduce ovarian cancer. So, and what is it and what is the importance? It's a banana. Banana contains tryptophan, which is converted to serotonin. I always remember talking about the antidepressant, natural antidepressant. Banana is a natural antidepressant drug which contains a lot of tryptophan, which is converted to serotonin. That should be considered as a natural antidepressant drug. So, alarmed by the very high incidence of cancer in the Western countries, the National Cancer Institute of United States put forth a novel program, which they call as the Fire Day for Better Health. What they say is that if you eat with different types of fruits and vegetables, that may be very good for your health. Now, there's a changing trend in Mollywood. Let's see, what is the dressing pattern, change in the dressing pattern of Malayalam heroines. Who is this?
Kumari.
That's absolutely right. Elizabeth Dr. Lelitha.
Dr. Indira.
Madam.
She was a favorite heroine when I was in school.
This is Miss Kumari. Look at the way she is dressed. So modest. This is Padmini and this is Sree. So this is how the current heroines are dressing. So there is a big trend in the dressing pattern of Mollywood heroines. Similarly, there is a big trend in the eating pattern also. See, our forefathers used to get plenty of fruits and vegetables. They used to get plenty of antioxidants by eating fruits and vegetables like that, and they were very healthy. But what is the present generation eating? They are eating only junk food, fried chicken, etc., junk food, and they have become extremely obese society. I'm not going to discuss obesity, will be discussed by Dr. Priya. Well, you can see that even these animals are aware of the importance. Even we are not aware of the importance of antioxidant, but these little animals, the cute little animals, are aware of the importance of antioxidants. This is one of my favorite heroes, Jairam. This is an old photograph of Jairam, taken almost 25 years back. He had a kitchen garden of his own in his flat in Madras, and you're getting tons of fruits and vegetables, which was distributed free of cost to fellows such as the friends in the film industry. And just look at Jairam. He looks so handsome because he was taking all these fruits and vegetables. And even after 25 years, you can see Jairam, in spite of the
Gray hair.
he still looks so handsome and young, in spite of the hair. He looks so handsome because he continues to eat fruits and vegetables. You know that she's 50 plus, and the King Khan is also 50 plus. So it's hard to believe that they're 50 plus. And see, they're almost 70. Can you believe that both of them are on the verge of 70? 75. Professor Kalam died at the age of 85. VS is going strong at 94. One of our outstanding prime ministers of our country was Adol Bihari Vajpayee. Was a very healthy person. He lived to his 90s. Muthuvel Karnanidhi, again 90s. Krishnayar, 99, and the leader. All these people are very healthy. Now, why were they healthy? They were healthy because they're all in the habit of taking fruits and vegetables. So simply by taking plenty of fruits and vegetables, you can be like them. So David Berkeley had mentioned in 2003 about fruits and vegetables. What he said was that the news isn't that fruits and vegetables are good for you. It's that they're so good for you that they could indeed save your life. And Hippocrates, father of medicine, had once remarked that health is the greatest of all human blessings. Let food be your medicine. Now I'll go to the last part of my topic. Prashant, am I running out of time?
How many more slides, Doctor?
But I'll try to finish as early as possible. I'll even skip some slides. This is the definition of jaundice. The genesis of the word jaundice is quite interesting. It was actually derived from a French word called jaundice. And as the French word jaundice crossed the British Canal and reached England, the English people were not willing to accept the term as such in the English language, maybe because of the political rivalry between France and England. Here you can see this wicked-looking Englishman with a crooked smile on his lips, inserting a D to the jaundice to change jaundice to jaundice. And that term is stuck and became quite popular amongst doctors all over the world, much to the chagrin and dismay of the French people. I think I will skip this slide. These are some of the synonyms of jaundice: icterus and morbus regis or royal illness. Why is it called icterus? Icterus is actually a bird called the golden oriole, whose zoological name is Icterus baltimore. Maybe because of the resemblance of the feathers of icterus bird to jaundice came to be known as icterus. Jaundice came to be known as icterus. And now, why is it called a royal illness or morbus regis? The ancient Romans, they were crazy about gold. So they were fond of anything that looked like gold. And since jaundice being resembled gold to them, they called jaundice as a royal illness. Here you see, who are these people? Elizabeth Taylor, again Elizabeth Taylor as the Cleopatra, and her husband Richard Burton as Mark Antony in the English classic Cleopatra. You can see that not only her hair, but also her blouse sleeves are full of gold. Where is jaundice better seen? It's seen in tissues which are rich in elastic fibers and poor in melanin. Now, who is this lady and what is the relevance to jaundice? Anybody who is this lady? What's the relevance to jaundice? Anybody? Well, this is Sohailican. What has Sohailican got to do with jaundice? Who is this? When I show this slide, most of my PG says that this is Sohailican's father. This is not her father. This is Moshe Dayan, the famous Israeli journal. This is her father, Mansur Ali Khan of Pataudi. What is common to Moshe Dayan and Nava Pataudi? Both have got an artificial eye. Okay, so if they develop jaundice, what will happen? There will be unilateral jaundice. That's the relevance of Sohailican to jaundice. So this is the unilateral jaundice due to artificial eye. Now, can there be unilateral jaundice? Yes, this child has got right side hemiplegia, and if he develops hepatitis, the right side will be less thin. So there can be unilateral jaundice, not only uniocular jaundice, but also unilateral jaundice. This is the classification jaundice, which I'll skip. Now, there are several things in the world which never change, like the immortal Taj Mahal. Okay, Taj Mahal never change. And there are two people as they will never change. One is, of course, Zulfikar Ram, and the other one is Elizabeth. They exactly the same as I saw them way back in 1981. So Sulfikar no change illa. Just look at Elizabeth. She looks so young. Absolutely no change for Sulfikar and Elizabeth. So unlike Taj Mahal, which never changes, and unlike Sulfikar and unlike Elizabeth, who never change, medicine is a never changes subject. You can see the change in the Trivandrum Medical College. See, this is the Calicut Medical. So lots of changes in the Trivandrum and Calicut Medical College. So medical students like myself, we are fortunate because we have to study only about 2 hepatotropic viruses. You can hear this kind. Elizabeth, you remember this slide, this photograph? When you came to Calicut for the KMCT, okay, you can see
Yes, yes.
Dr. Shree, Sulfi, Dr. Balraj, and
Dr. Balraj was the organizer.
that was the organizing chairperson. So we are fortunate because we have to study only about 2 hepatotopic viruses because we studied medicine 40 years back. The only young person who is the only young person, truly young person is Naveen. Naveen is the only young person. So we are lucky because we have to study only about 2 hepatotopic viruses, hepatitis B virus and the A virus. But the present generation students like you and many of you in the audience are not going to be that lucky. Why? Because the number of hepatotropic viruses seems to be increasing at such a rapid speed, at such a tremendous pace that even the letters of the English alphabet find difficult to keep pace. You know that there are 7 hepatotropic viruses, newer and newer hepatotropic viruses are being described. So the present generation students will have to study all this. Now this is the scene in Mavu Road of Calicut. I'm sure you know what this is. The people standing in this queue. കേരളത്തിൽ ഇത്രയും മര്യാദയിൽ ആൾക്കാരുണ്ടെന്ന് നോക്കിയാൽ ഈ ക്യൂ കണ്ടാലും അറിയില്ല. Okay? Can it cause liver disease? Yes, alcoholic liver disease, and children can develop alcoholic hepatitis. Adolescents. The other one is the queue in front of fruit shops. Now, especially medical students are so fond of fruit juices that if they take such fruit juices in unhygienic circumstances, they can develop various types of fecal-oral transmitted diseases, including hepatitis A and hepatitis C. Not only that, cholera, typhoid, etc. Hepatitis B is an extremely infectious condition. 1 ml blood contains 1 trillion viral particles. The infected dose is extremely minor, just 0.0001 ml of blood. The bacterial hepatitis, protozoal hepatitis. As a pediatricians, we should always be aware of metabolic liver disease also. The most common metabolic liver disease which I have come across is Wilson disease. But of course, we have got galactosemia, fructose, and all this can present with jaundice. And drugs are also notorious to cause hepatitis. What is High's law? Hyman Zimmerman, the famous clinical hepatologist, had once remarked that if a patient is on, say, anti-TB drug and the SCPT becomes 3 times above the normal of jaundice, and there is jaundice, then the chance due to drug toxicity, the mortality is going to be very high, almost 10 to 30%. So you always monitor transaminase when the patient is on ATT. What is the most important clue to the diagnosis of jaundice? Just like this famous Alfred Hitchcock thriller, Suspicion, starring Cary Grant and John Fonda. Suspicion is very important. You should always try to rule out other conditions. How do you approach a child with jaundice? History taking is extremely important. In fact, I have written history thrice. Not that students should write 3 times in the answer paper, but you should take a proper history, then you do a meticulous physical examination and investigation. So pediatrics should really be like Sherlock Holmes. So very little suspect neonatal cholestasis. When a neonate has got high-colored urine, diapers are stained, clay-colored or pale stools, what are the causes of neonatal cholestasis? Or what are the cause of delayed referral of neonatal cholestasis? Usually, the pediatrician may misdiagnose this as physiologic jaundice, improper follow of neonatal jaundice. You should never ignore the mother's complaint that the urine is high-colored, and there may be some amount of physiologic diuresis immediately after birth. And people are so fond of leaf, it's called the leaf 52 effect. And some people expose the baby to sunlight, which is called heliotherapy. Pediatricians who are not aware of the importance of cholestatic jaundice may adopt what's known as the wait and watch policy. They may try non-specific drugs for cholestatic liver disease, and they will be referring patients quite late. So this is known as the road roller pace of evaluation. Padka investigate a road roller pace of evaluation. And now, thanks to the efforts of IAP, ISGAN, and pediatricians are really aware of the importance of neonatal cholestasis, and they are referring these babies promptly. So this is known as the fire brigade pace of evaluation. Now, what is common to obstetricians and pediatricians? Prashant Kadiyarayata, just 1 or 2 slides more. What is common to pediatricians and obstetricians? Obstetricians always exhibit what is known as watchful expectancy and maternal inactivity. So a pediatrician should be like obstetrician, exhibiting watchful expectancy and maternal inactivity when you are treating a child with hepatitis. So in conclusion, in the evaluation of a child with jaundice, there are two important questions to be asked. The first question is, what is the color of the urine? If the mother says the urine is a normal color, is it unconjugated jaundice? Do investigation for hemolytic disease. If the mother says the urine is high colored, like this, that's a conjugated jaundice. So you ask the next question, what is the color of the stool? If the mother says the stool is of normal color, it's going to be hepatocellular jaundice. You do the workup, medical workup. But the stool is pale, you do the investigation for cholestatic jaundice. Finally, you should always believe the mother. When a mother who's a jaundice is worried, pediatrician should also be worried because she's likely to be correct. Always, the pediatrician should always be worried, but the mother is also worried because she's likely to be correct. Finally, Sir William Osler, the father of medicine, had once said that the young physician starts life with 20 drugs for one disease, while the old physician ends his life with one drug for 20 diseases. So the story is that the moral is that the pediatrician should prescribe as few drugs as possible. And this talk is dedicated to one of my best teachers in gastroenterology. Narendran Sir, former HOD of medicine, is one of the best gastroenterologists of our country. He's an awesome academician, and he's also a wonderful, very difficult. I've not seen him for a very long time. Please do convey my regards to him. He's a wonderful human. Such a wonderful human being. And this talk is also dedicated to Professor Ramamurthy, late Professor Ramamurthy, passed away just a few days back. And Ramamurthy sir he taught me the value of showing empathy and sympathy to poor patients. Sir, we should show not only empathy, but also sympathy to poor patients. And sir made a famous quote. I'll stop with his famous quote. Doctors should be sellers of hope. Doctors should really be sellers of hope. Thank you so much for listening to me.
Thank you, Dr. Riyaz, for that brilliant and comprehensive talk. You were blending art, science, words of wisdom, and everything about gastroenterology, hepatology. And we are very thankful to you for sharing all the pieces of wisdom and pearls from your collection. I think there is one question, that is which drug to be given when a child has not passed motion for 7 days?
When a child has not passed motion for 7 days, that means that he's having a stool impaction. Okay, when there is a stool impaction, it's very important to remove the stool impaction. Can be done from higher above. That is good. A higher dose of PEG. The usual dose of PEG is 0.2 to 0.8 gram per kg, but you can give a higher dose of PEG, polyethylene glycol, 1.5 gram per kg for 5 to 7 days. Or a better option would be to give an enema, glycerin enema. The problem with enema is that the children are usually frightened of enema. Once you do an enema, you may not come to you again.
There is one more question, that is, what is the difference between chronic diarrhea and persistent diarrhea?
This is a huge topic, like chronic diarrhea. I just say in a single word. A persistent diarrhea starts as an acute diarrhea. It's an infective pathology. But a chronic diarrhea is due to some other cause. It's not an infective pathology. You think of conditions like malabsorption, celiac disease, and so on and forth.
Any youngest age to give PEG?
PEG. Okay, there are lots of studies that PEG is a very safe drug. The only thing is that if you've got a very small baby, suppose you've got a 3-month-old baby with constipation, then you need to rule out other causes. If you're only for sure that is the functional constipation, can you give laxatives including PEG? There are studies that show that can be given in children below 1 year of age also.
What is your take on mesenteric adenitis as a cause or effect for abdominal pain?
So mesenteric adenitis.
In one sentence.
Yeah, that's a very
because we are running short of time.
So
Priya is waiting for a long time.
Yeah. So mesenteric adenitis, we got, all of us got lymph nodes of the inguinal region, especially children, because they're exposed to infections. Similarly, a child may be having very frequent infections of the GAT. whenever there is some infection in the GIT, it's quite possible that just like the inguinal nodes, the mesenteric lymph nodes also enlarge. So there are some clues by the radiology. Number one, the size of the nodes. If the nodes are less than 10 millimeter, that's okay. Location is very important. If there are typicals like para-aortic area, retroperitoneal, one has to be careful. If the fatty hilum or the lymph node is preserved, that's okay. If there is matting, that may be significant. Okay, or the child is symptomatic, he is losing weight. Otherwise, they can ignore.
I think there are a few questions. Dr. Riyaz can type the answers in the chat box. I hand over the mic to Dr. Praveen to continue. Dr. Prashant and Dr. Praveen.
Thanks, Riyaz sir, for the wonderful lecture, and thanks to Elizabeth Madam for chairing this session. Now, I call upon Dr. Anju Deepak Madam to chair the next talk and introduce the speaker.
Good evening, all. Thank you, Dr. Prashant, for inviting me. Respected senior pediatricians and dear colleagues. As Santhosh sir said, today on the eve of the World Digestive Health Day, this year's theme is obesity and ongoing pandemic. What other best day than today to discuss about infant obesity? We all know that gone are the days of plump babies being taught as healthy babies. And all of us pediatricians know that obesity in infancy is no more to be ignored. We all know that infant obesity is something that has to be taken seriously, and childhood obesity itself is a challenging topic. And we all know that infant obesity is more likely to go into adulthood also as obesity, and hence it has to be prevented. So we should also know about the risks of the developments of excess weight in infancy, how to diagnose them early, and what are the interventions that we have in the present day, and what are the challenges in actually implementing them. So to talk about this, we have none other than our expert in nutrition, Dr. Priya Srenivasan, who's the Associate Professor of Pediatrics in SAT Trivandrum. We all know her as the very dynamic secretary of IAP Thiruvananthapuram of last year, and also the treasurer for the year 2017 and 18. She has also been the convener of the nutrition chapter of IAP Kerala in 2018. And she's also written many articles in international and national index journals, and she's also the author of a chapter in Parthasarathy's textbook of pediatrics. We all know that she has won the best research paper award at the state Pedicon in 2016, and she has also won the India Clin National in 2017. She is also the recipient of the Ramdas Pisharadi Memorial Best Clinical Research Award in 2017, and also the first rank holder of M.Phil of KUHAS in clinical epidemiology in 2018. She is a principal investigator of research projects of ICMR, CMC Vellore, and Government of Kerala. And she's also the state level IYCF trainer. We all know her as the organizing secretary of the recently conducted NutriCon 2019 and the National IYCN and HMBCon. Welcome, Dr. Priya Srenivasan, and over to you.
Thank you. Thank you, Anju, for that very, very long introduction. Actually, you have taken that introduction from the IYCN conference. I
thought it was high time to introduce you officially to our group.
Good evening to all. First of all, let me thank the organizers for giving me this opportunity to present infant obesity. Is my slide visible? Anju, is my slide visible?
Yes, visible.
Yes.
Continue.
Yes, and it is indeed a proud moment, a very happy moment for me to share the Zoom dais with Riyaz sir and Elizabeth Madam. So let me start. See, the theme for World Digestive Health Day, as you all know, is obesity and ongoing pandemic. So that's why the topic given to me is infant obesity, myth or fact. So I'll describe under these headings, that is the available data on infant obesity. Now, why are we more concerned about infant, and what is the definition in an Indian setting? And infant versus child, the determinants do differ, that is the modifiable risk factors. and clinical approach and management, which is a case-based. That is, I'll deal with the 4 case scenarios, very simple OPD case scenarios. Now, regarding the available data is available only with these under 5 child. That is, there is no data available like infant obesity data. Now, the WHO Global Estimates 2019 tells us that 38.2 million under 5s are either overweight or obese, and 50% of them live in Asia. And according to the Comprehensive National Nutritional Survey 2018, it tells that the prevalence of under 5 obesity or overweight is to the tune of 2%. And Kerala, the prevalence is 1.7%, whereas Nagaland and other northeast states, the prevalence is high, that is 8%. And in Kerala, that is the NFHS 5 data, which gives, that is the 2020 data, tells us that the under 5 overweight is, the prevalence is 4%, whereas the 5-year back NFHS 4 data tells us that it was only 3.4%. Now, why we are focusing on the infant? So that is whether to start with the infant, that is under 5 means whether to start with the infant or with the child. And later it will progress to adolescent obesity and adult obesity. So where to start? That is the question. Now, if you look at the data, that is the 2016 global data given by WHO, we know that the numbers are increasing with age. That is 41 million under 5s, 380 million 5 to 19 years, and 1.9 billion adults. So the numbers are definitely increasing with age, and it is linked to more deaths due to non-communicable diseases worldwide than underweight. So we were more concerned about underweight. Now we should be more concerned about overweight as well. And the numbers are actually increasing with time also. So that is in 1975, the prevalence among children and adolescents were 4%. And now in 2016, the prevalence has increased to 18%. So where to start from? Is it from infancy or is it from childhood? Now we know about the Barker hypothesis, that is the fetal onset of adult disease, which is now known as the developmental origin of health and disease. According to which, we know that the maternal insults due to maternal malnutrition or gestational diabetes or whatever it may be can result in SGA babies and LGA babies. And it results in epigenetic programming of the fetal organs. That is, they will be switched towards obesity. Now, what do you mean by this epigenetic programming? Simply telling you that is, you can see a DNA sequence here. There will be no change in DNA sequence, but there will be change in the gene expression. So that is because the most common epigenetic programming that is happening is the DNA methylation, which means a cytosine will be converted to 5-methyl cytosine, for example. And what happens is that the fetus, the different fetal organs will be switched more towards obesity. And along with this, there will be an added postnatal overnutrition, overfeeding will be there, especially for SGA babies. And this will result in rapid postnatal weight gain. So it is an intergenerational issue actually. So you can see that it doesn't start from the infant, it actually starts from the pre-pregnant obesity, and then fetus, then infant, then child, adolescent, and adult. So now infant has come in the middle part. So it is actually not a myth. And parental obesity, if one parent is obese, the chance for obesity or overweight in a child is 30%, and it increases to 70% if both parents are obese. And gestational weight gain more than expected. So that is another modifiable risk factor. Now, gestational diabetes, hypertension, and maternal smoking are also associated with obesity, that is childhood obesity. So finding out that this is a major issue, the WHO has come up with different strategies and has put forward the different strategies in this module, that is the Ending Childhood Obesity, which came out in 2017. And the third strategy, what it tells is that the current guidance for preconception and antenatal care to reduce the risk of childhood obesity. So the recommended gestational weight gain, now earlier we used to learn like it is a blanket statement like 12-gram increase. It is not like that. That is the recommended gestational weight gain depends upon the pre-pregnant BMI status. So if the mother is underweight, that is less than 18.5 BMI means the recommended weight gain is 12.5 to 18. Whereas if it is the mother is overweight or obese, the recommended weight gain will be less. And this chart was put forward by the Institute of Medicine, that is learned by learning the US women of upper class in 2009. But we know that actually it is not applicable to Asian women or Indian women, but such charts are not available. And another point is that here BMI, overweight and obesity is more than 25 and 30, whereas in our population, the overweight and obesity starts from 23 and 27. Now, the undefined definition of overweight and obesity in an Indian context depends upon the WHO weight for height charts. Now, you have to use the Z-score charts. And in the Z-score charts, if the point comes above the 2 line, it is overweight. And if it comes above the +3 line, it is obesity. You can also use the BMI for age chart. But the thing is that it is better to use the weight for height chart, because if you teach the healthcare worker the weight for height chart, she'll identify the moderate acute malnutrition as well as the severe acute malnutrition also in this chart. So it is better that we teach how to deal with this weight for height chart. They know already the weight for age chart, which is available in the immunization card. Now, CDC also recommends the WHO weight for height charts in less than 2 years of age. Why? Because the CDC 2000 charts are available for more than 2 years only. And when it comes to the CDC charts and the WHO 5 to 19, that is for bigger children, the BMI for age is taken and the cutoffs are +1 and +2. Now, why this difference? So there is actually a confusion, but the WHO tells us that the cutoff is +2 and +3 when you take the WHO charts. It is because for statistical reasons, while constructing the WHO charts, the heaviest children were excluded. That is purely for statistical reasons. And so the upper centiles have come a bit restricted. It has been made a bit restricted. So if you take the +1 and +2, the prevalence of overweight and obesity is going to be very high. So that is why, for purely statistical reasons, WHO has put up the cutoffs as +2 and +3. Now, we know that infancy is actually a critical period. The latter part of infancy, physiologically, there is an increased chance of adiposity. And more than that, there is 70% of polygenic obesity. That is the common obesity which we see. 70% is due to the genetic susceptibility, and 30% is due to the different determinants. By determinant, what I mean is that modifiable risk factors. That is the obesogenic environment, like the nutrition. Now, when it comes to infants, it is the breastfeeding and complementary feeding. Then we have guidelines on physical activity and sleep. The psychosocial care, what I mean is the responsive feeding. And again, the epigenetic tuning, which is happening to the baby's birth weight, that is SGA and LGA. Now, let us see the first scenario. That is a 3-month-old baby whose weight is now 4.8 kg. He was a preterm baby, 34 weeks, with a birth weight of 1.8 kg. Now, he is on breastfeeds and formula feeds. Now, this situation I plotted in a Fenton chart, which is akin to the intrauterine chart. You can see that at birth, at 34 weeks, it is between the 10th centile and the 50th centile. And at 46 weeks, that is the 3-month-old. So 46 weeks, again, it has gone a bit up, but still between the 10th and the 50th centile. Now we have another chart to introduce with respect to preterms. You have now the intergrowth 21st chart for preterm babies more than 32 weeks. Now I'll tell you the difference. Now this is an extrauterine chart. Now here I have plotted the same situation. You can see that by 34 weeks, it is between the 10th and the 50th centile. But at 46 weeks, it has touched or even crossing the 50th centile. So that is the difference. So Fenton's chart is actually an intrauterine chart. That is, it tells us how this baby grows if this baby was inside the womb of the mother. So it is actually not a realistic chart, because intrauterine growth, that is the intrauterine environment is different, intrauterine nutrition is different from the extrauterine life. So you are over-diagnosing extrauterine growth restriction here, and there is more tendency to overfeed such preterm babies, and a rapid weight gain is possible. So if you use this intergrowth 21st chart, actually this chart came out in 2016, and it has been endorsed by the American Academy of Pediatrics, and actually it has been taught in the NEPU module of IAP. So it is actually a prescriptive chart, a realistic chart. It is same as that of WHO. That is, it tells us how extrauterine, that is, this preterm babies should grow in the extrauterine world. It avoids overdiagnosis of extrauterine growth retardation, and it can be plotted till 64 weeks and then move on to the WHO chart. Now, 10% of preterm babies are below 32 weeks of age, and in that situation, you cannot use the intergrowth chart. there is no consensus actually, but in Nelson, what it tells is that if such babies are below 2 kg, you can use the calculation like 15 to 20 grams per kg per day, and more than 2 kg, you can use 20 to 30 grams per kg per day till 40 weeks. Now, regarding complementary feeding in preterms, again, there is a controversy like when to start. But a systematic review has come up in the Nutrients Journal in 2020, which tells that in preterms, taking into consideration the chronological age, these babies can be fed. That is, complementary feeding can be started from 5 to 8 months of age. So why? Because this range is because these babies should be developmentally mature. That is, the head control should be attained, the tongue thrust should go. So these things should happen. So provided they have reached, so the very small or 28-week babies, make sure that babies are at least 3 months corrected age. So that is the latest recommendation. Now let's move on to the second scenario. There are two low birth weight babies, actually 1.8 kg babies. And now by 10 months, these babies are 9 kg and 7 kg. The first baby is given breastfed, formula fed and complementary feeds. The second baby is given breastfeeds and complementary feeds. Now you can see the weight for age chart, which is plotted in the immunization card by the healthcare worker. The baby A, you can see that the baby A has crossed 2 major centiles and is actually touching the third major centile, whereas the second baby is yet to cross the second major centile. So in the first baby, you know that there is an early catch-up which is happening. So overnutrition in early infancy, crossing centiles, and so such babies, there is a high chance of metabolic syndrome to be developed later in life, according to the Barker hypothesis. Metabolic syndrome means we all know that there will be adiposity. So it results in insulin resistance, and that can result in dysglycemias, diabetes mellitus, then dyslipidemias, and hypertension and cardiovascular disease. Whereas the second baby is slowly catching up, and you do a thorough physical examination. If you find that the baby is healthy, accept these small but healthy babies, and the aim should be maintenance of weight for length rather than weight for age. And you have to monitor the growth of such babies carefully. Now, exclusive breastfeeding till 6 months and continuing breastfeeding till 2 years is very, very important to prevent infant obesity. Now, in breastfeeding, the volume, there is an inherent self-regulation by the mother-baby duo. And there is a responsive feeding. The mother can look into the hunger cues as well as the satiety cues. The contents of breast milk, it contains human milk, oligosaccharides, leptin and all, which prevents obesity. And one should understand that each feed is different. So when you consider a 24-hour breastfeed, each breastfeed is different in the aroma, the taste. So that is because such babies, such mothers, they will be on a different diet. So she'll be taking a breakfast, lunch. So there will be a dietary diversity, and it will affect the breast milk also. And there will be hydration. So hydration status is different, diurnal variation will be there. So each feed is different, and the baby experiences a dietary diversity. And such babies will be able to accept the dietary diversity, which will be given later, that is after 6 months of age. And the risk of overweight is reduced by 4% for every additional month of breastfeeding after 6 months. So, so that is the importance of continuing breastfeeding till 2 years of age. And regarding this formula feeds, excess of protein, you know that in formula feed, the amount of protein is more than 2.4 grams per 100 ml. And so there will be excess protein, and there will be insulin releasing amino acids as well, which are obesogenic. So these formula fed babies, they are more chance of early weaning, bottle feeding, forceful feeding, overfeeding. So all these can result in infant obesity. Now we'll see the third scenario, common scenario which we see nowadays. That is a 10-month-old baby, now 12 kg with 72 centimeters. Now we know that it rings a bell, that is 12 kg. It is more likely to be overweight or obesity. In such situations, always teach the healthcare worker to use the weight for length chart. And here you can see that the point is above the +3 line. So it is an obese baby. You take the history, it is a term 3 kg. But the baby has been breastfed only till 4 months of age, then breastfeeding is stopped. And now the baby is on complementary feeds with a cereal-based diet, that is more of Cerelac, ragi, biscuits, fruit juice, and there is bottle feeding as well. So what is the diet? What kind of diet such babies should get? Now, according to WHO, now babies from 6 months to 23 months should get at least 4 food groups from the 8 food groups. Now, what are the recommended 8 food groups? That is, we should see this the food plate concept. Now, as Riyaz sir has already told, it is very colorful. That is fruits, again divided into vitamin A rich fruits and the simple fruits. Then you have vegetables. So this should comprise half of the plate. And then 1/4 grains, and the protein again divided into the 3 types. That is the plant protein, which is the dal, legumes and all. Then you have the animal source protein and the egg protein. When you consider the animal source protein, it is important that before 8 months of age, these babies should be introduced to animal source protein like the chicken, meat, fish and all, because after 8 months, these babies, they develop their own likes and dislikes, and so they may not accept these the food which is given at a later stage. They'll develop neophobia. So, and then the dairy products. So that is the 8 food groups. So on a daily basis, these babies should get at least 4 out of the 8. So if such dietary diversity is given, the chance of these babies getting more of grains or more of this obesogenic food will come down. And the meal frequency also WHO has told, that is 6 to 8 months breastfed babies, they can take 2 to 3 feeds. That is more than 4 feeds, it is actually not necessary. And 9 to 11 months, again 4 feeds, or more than 5 feeds actually is not necessary. So 1 or 2 snacks can also be given, and the quantity also, it is half 250 ml bowl, you should give half a bowl. And now this is endorsed by the ESPGHAN guidelines as well as the WHO guidelines. That is, you have to avoid all kinds of added sugars in complementary feeds. Free sugars are a big no. Do not give honey, and do not give fruit juice even, because all of us give fruit juice to small babies. That is, but less than 2 years of age, fruit juice should not be given. Now, why? Because this fruit juice will be consumed in large volumes and will displace the breast milk. And fruit juice contains lots of sugars. Free sugars are there in plenty. Now, if you take a whole fruit, there is not much of a problem, because it is taken in small amounts, and there will be intact cell wall. The sugars are inside the intact cell wall, so the chance of obesity will be less. Whereas once you crush the fruit to fruit juice, the cell wall breaks and it releases free sugars, and that is more dangerous. And whole fruit contains fiber also, so it prevents constipation. So fruit juice is a big no. And with or without added sugar, it is a big no. And biscuits should not be taken because it is a processed food. It is just like a junk food. And cereal-based commercial food also is a big no, because it contains added sugars as well. And responsive feeding, that is the psychosocial care I was talking about. That is, it should be happy moments, and both the mother and the baby should have a eye contact, and both it should avoid distractions like the media distractions. And the baby should be concentrating on the food. That is, the baby should learn the color of the food, the shape of food, the aroma, the texture, the flavor, everything the baby should understand, so that neophobia will be less. And the mother should understand the cues of the baby, both the hunger as well as the satiety cues. Once the baby shows signs of satiety, stop feeding the baby. And again, self-feeding. So when the baby starts, by 10 months or so, the baby starts self-feeding. And that also prevents obesity to a large extent. And regarding the physical activity, WHO has come up with guidelines for children under 5 years of age. And this is in infant less than 1 year of age, a physical activity of at least 30 minutes should be given. That is a tummy time. For less than 6 months, it is the tummy time. The baby can be put on its own tummy, and the baby can play over his tummy. That is by moving his hands and feet. Limb movement. So that is 10 minutes, 10 minutes, 10 minutes, morning, afternoon, and evening. You can try this. So that is the 30 minutes. And after 6 months, according to the developmental age, the baby can be given small play activities. Screen time, it is a big no. And sleep is also very important. Till 3 months, the baby should get at least 14 hours of sleep. And after 3 months, the baby should get at least 12 hours of sleep. And this is the last scenario, the fourth one. That is a very common problem which we encounter nowadays, but a very vexing problem indeed. That is the exclusively breastfed obese baby. That is what I was telling about. You cannot consider polygenic obesity here, because there is only the genetic susceptibility. There is no obesogenic environment. So no modifiable risk factors in this situation. So the baby is exclusively breastfed, the baby is getting adequate physical activity, then what to do? In this situation, you should consider genetic as well as hormonal conditions. That is the 2 types of genetic situation. That is the monogenic obesity. Monogenic obesity means mutation, single gene mutation that is happening. And the most common single gene mutation associated is mutation of the MC4, that is the melanocortin 4 receptor gene. So that is the most common one. But all these conditions are very rare. Then you have the leptin gene mutation or the leptin receptor mutation. Then you have the pro-opioid melanocortin deficiency. So in all these situations, the appetite control is lost and there will be hyperphagia. So obesity starts in early infancy itself. There is a dramatic weight gain. And in all these situations, but the length will be normal, unlike in syndromic or in hormonal conditions. And sometimes in, for example, the common one is the MC4R gene mutation. So here, even the length will be accelerated. The stature will be accelerated. Now you have the syndromic obesity. Now we have learned different syndromes like the Prader-Willi syndrome, Bardet-Biedl-Cohen. So different syndromes we have learned, and all these come up to our mind when we think of obesity. But we should understand that obesity as a feature, it appears late if it is syndromic. So only after infancy, obesity appears as a feature. Now in these syndromes, what happens is that it comes to our attention because of the other manifestations like family history, dysmorphism, like major organ involvements, retinal dystrophies, developmental delay, and even hyperphagia. But obesity as a feature, it appears usually after infancy. And in Prader-Willi, actually, these babies, they may present to us in infancy with failure to thrive because they may be having hypotonia and sucking issues and all. Now, endocrine issues, the most common one is hypothyroidism. So always in such babies, send for a thyroid function test. You can assess the bone age, and the length for age is also important. And very, very rarely, Cushing syndrome may present as obesity, infant obesity, and again, very rarely hypothalamic, like suppose there is a tumor or suppose of flying surgeries or radiation. So, but such situations are very rare in infancy, and always ask about drugs because these babies may be on some steroids or some indigenous medication which contains such components, and anti-epileptic drugs also. Now, whatever said and done, such babies, most of these babies, they may put on weight, but after or on the later part of infancy, what happens is that what we see is that these babies somehow they lose their weight and come back to normal. So close follow-up, that is what is needed. The close follow-up of growth with weight for length charts are mandatory for such babies. So you should keep them under follow-up. So summarizing, infant obesity is not a myth, it is a fact. And the common one is the polygenic obesity, but there should be a genetic susceptibility in 70%, and then 30% is of course the obesogenic environment. And practice exclusive breastfeeding up to 6 months and continue till 2 years of age. Complementary feeding is important, and consider the dietary diversity, the meal frequency, avoid all types of free sugars, fruit juices, biscuits, and the physical activity, sleep, and psychosocial care is important. And genetic and hormonal evaluation need to be done only in very selected situations. And the most important thing is that we should closely monitor the growth with weight for length chart, and we should teach each and every healthcare worker how to use the weight for length chart apart from the weight for age chart given in the immunization card. Thank you.
Thank you, Dr. Priya. It was a very clear presentation, and you have stressed the point of somebody had asked a question also, how to investigate the infant obesity. So plotting in the weight chart is a very important measure, that is height to length and height to weight and even age to weight chart, than following up the standard weight charts. I would request now Dr. Prashant to take up any questions if it is there in the chat box, and also if no questions, maybe Dr. Priya, you could just speak a little about obesity in this COVID times, which, as Santhosh said in the opening remarks, we all are facing. Parents are also complaining of mostly inactivity of the children and a lot of snack eating as they are sitting at home. How to deal with that?
Yes. I think they should be taught about what is happening, like because there is more of Swiggy eating, and physical activity is very less. I think we should stress more on the dietary diversity. So whatever said and done, they should take more of fruits and more of vegetables along with the Swiggy initially, and probably you can build up the fruits and vegetables and come down with the this Swiggy eating. And I think what is happening now is that when we are stressing on homemade foods, they are making more of homemade junk foods. So that also should be reduced, and physical activity is very, very important. When you consider more than 1 year of age, the physical activity, what they tell is that 180 minutes, so that is 3 hours of physical activity is needed for under 5 children. So that should also be taught to these mothers. So that is what I feel.
Okay. Another problem that practically I have seen in the OPD is that now most of the mothers are work from home. So they are frequently feeding their infants.
Yes.
And we see a lot of even solely breastfed babies crossing the growth charts. So is there any particular advice we have to give to those mothers, or can these babies without any hormonal or syndromic diseases, can they be left alone, or should we give some particular advice to the parents?
Yes, I think what we need to do here also is that we should teach them the dietary diversity and the meal frequency. So here the problem may be meal frequency, and again more of snacking. So actually, in case of infants, that is till 8 months, it is you need to give only 3 or 4 feeds if you are breastfeeding the baby. And again, more than 5 feeds is actually not necessary. And what WHO tells is that if you are giving more than 5 feeds, the mother actually cannot prepare more than 5 feeds a day. So what happens is that it is not freshly prepared, and she will be giving the old stale food that is prepared in the morning hours. She will be giving it in the evening, and that will result in more of contamination and diarrheas. So the meal frequency is very important, and again physical activity.
Okay. And there's a question about the role of gut microbiota in obesity. Is there any evidence?
Yes, lots of evidence are coming up. Again, gut microbiota acts in the same way as that of this epigenetic programming. So it is said to be, there are actually 3 limbs that is described. So first is the epigenetic programming, then you have the nutrition as such, and then you have the gut microbiota as well. So a lot of studies are coming up in that situation, but actually drugs or probiotics or drugs are not recommended. Till now, drugs are not recommended for obesity, but lots of studies are coming up.
There's another question: at what age is taste developed?
Taste?
Yeah.
Yes. Taste. I'm not sure. I'm not sure. But regarding the likes and dislikes, it develops by 8 months. Taste buds, I'm not sure. I think it appears after the newborn period. I don't know. Madam, Elizabeth, madam. Elizabeth, madam. I can see Parvati, madam.
Yes.
Good evening, madam. Parvati, madam.
Dr. Prashant, I think you can continue and give your take on the topics too.
Actually, both the speakers have done an excellent job, and they have done 100% justice to the title allotted with their crisp and clear presentation, as well as their vast experience has also been shared.
ഒരു ക്വസ്റ്റ്യൻ എനിക്ക് ഉണ്ടായിരുന്നേ, പറ്റുമെങ്കിൽ അല്ലെങ്കിൽ പ്രശാന്ത് ആൻസർ ചെയ്താലും മതി. അതായത് ഒരു സേ 1 month old ചൈൽഡ്. ഹലോ, കേൾക്കാമോ? 1 month old child presented with constipation and not pass stool for 7 days. Absolutely normal child. What is the drug of choice or enema? What you are supposed to give?
Theoretically, actually, this PEG can be safely used even in children less than 12 months of age. The PEG has no real contraindication. There are actually evidence coming up that even in small babies less than 12 months of age also PEG can be used for disinfection. There is no problem.
Okay. How do you dilute PEG, Dr. Prashant, when it is 1 month old baby in breast milk?
Yeah, 1 month.
That is a practical thing. Another option would be like you can use glycerin enema. That will be a safest option.
See, one product available which is I used to use, whether I can use it complete or not. That is why I want to know.
Which one, sir? Which one?
Saline enema. Is it possible to continue to?
Saline enema is also advised actually. Saline enema is also advised. Is also advised.
Okay. That's saline enema. Okay, thank you.
Dr. Priya, one more question has come. Should we promote the idea of baby-led weaning? How should it be done if so?
Yes, we can actually promote baby-led weaning. Baby-led weaning means actually baby will decide when to wean off from the mother's breast. That is, it is not like you have to stop breastfeeding at 2 years of age or on the second birthday. That day itself, you need not stop this breastfeeding. If the mother is okay with it, and if the baby baby wants to get breast milk and all, then you can continue. That is what you mean by baby-led weaning. But sometimes the thing is that these mothers may be working. So in such situations and all, this may not work. That's all. Baby-led weaning is okay. It's okay. As far as the mother can feed the baby, it is okay to continue with the breastfeeding. But the thing is that if you give, you should tell the mother that these babies should not be given breastfeeds alone, because what happens is that these babies will take only breast milk and then they'll play around, and finally they'll not be getting the adequate nutrition, because these breast milk cannot suffice. It will not give all the nutrients that is needed after 6 months, that we know. So it should be complementary feeding, and other feeds should be started after 2 years of age. Along with that, breastfeeding can also be continued. There's nothing wrong in it.
Another question has come that is, I think, on context to Bennett sir's question. When do we diagnose constipation in a month-old? I think that is because even very small babies, it's normal that they pass stools once a week.
Actually, there is an entity called as infant dyschezia. That is also thought to be a functional disorder. This is actually seen only in infancy. Maybe that is what the person who has asked the question is referring to.
Okay.
Riyaz sir also has alluded in his talk. Another point I wanted to ask Priya madam is regarding the composition of this Amritam body. If you go through the composition of Amritam body, the sugar content seems to be very
high.
Yes.
It's a matter of concern.
Yes.
If you go by the guideline.
Yes.
I'm asking whether we should have a stratification into two, because for less than 12 months and more than 12 months, or for the same preparation is advisable to all the age groups.
Actually, what is happening is that in the government setup, they are giving this Amritam body after 6 months of age. So in all babies above 6 months of age, they give this Amritam powder, which we know that it cannot be given. It will not. You cannot give this Amritam powder for more than 6 months of age. Again, it has got multiple proteins, so lots of protein, like there is kadala, soya bean. So lots of things. So you cannot actually give, and it has more sugar as well. And we had our own SAT mix, and now what we say is that SAT mix, the ratio was 1:1:1:2. Now Elizabeth madam has come up with the new SAT mix, which tells that sugar should be reduced to half. That is 1:1:1:1. So such revisions should happen. So that is important.
I think IAP should take it up.
Yes.
And what is your take on addition of salt in babies less than 12 months?
Again, salt is another important important thing which we should talk about. That is the salt recommendation is actually less than 5 gram. That is less than 2 gram of sodium, which means less than 5 gram of salt. That is what is. But for infants, there is no clear-cut guideline. Like in infancy, you should give this. It is not.
But a pinch can be. It is allowed to add into the.
Actually, what Spagan tells is that
less than 5 gram.
Less than 5 gram of salt ആണ് പറയുന്നത്. Less than 5 gram. അതില് 2 gram sodium. Less than 2 gram sodium. എന്ന് പറയുമ്പോൾ 5 gram salt ആണ് പറയുന്നത്. ഇൻഫൻസിന് പ്രത്യേകിച്ച് പറയുന്നില്ല, പക്ഷേ നോ ആഡഡ് സോൾട്ട് ഡയറ്റ് എന്നാണ് എസ്ഫഗാൻ ഗൈഡ്ലൈൻസിൽ പറയുന്നത്. നോ ആഡഡ് ഷുഗേഴ്സ്, നോ ആഡഡ് സോൾട്ട് ഇൻ കോംപ്ലിമെന്ററി ഫീഡ്സ്. ദാറ്റ് ഇസ് വാട്ട് ദേ ടെൽ. ടേസ്റ്റ് ബഡ്സ് അതെനിക്ക് ഐ എം നോട്ട് ഷുവർ സർ, ഞാൻ ചെക്ക് ചെയ്യാം.
I think we had a very exhaustive session today. I think Praveen is also he's engaged in another meeting, so on his behalf I am proposing a vote of thanks. Actually, I should thank IAP Thiruvananthapuram for giving the opportunity to conduct CME in association with the World, in connection with the World Digestive Health Day for the last 5 years. My special thanks to Santhosh Kumar sir, Secretary Praveen, and Treasurer Dr. Sree Kulip, and other office bearers for giving this opportunity. Thank you and good night.
Thank you. Thank you, Prashant. നന്നായിരുന്നു പ്രോഗ്രാം. വളരെ നന്നായിരുന്നു.